disorders, which is very important for you people, especially to know about the bleeding and clotting disorders. Though you don't need to manage, but you should know the consequences and complications in a patient with known bleeding clotting disorders before doing any procedure. So dental procedure resulting in bleeding can have serious consequences in a patient having bleeding clotting disorders. Evade knowledge can occur and even death. So it is necessary to know or to have the knowledge about bleeding and clotting disorders for every dental student. So before proceeding bleeding clotting disorders, you should know the basic mechanism of hemostasis in your body, or how your body achieve or arrest bleeding naturally. That is the hemostasis of body. How your body achieve or stop bleeding naturally. That is called as hemostasis. The basic mechanism of hemostasis. So it includes three phases: vascular phase, platelet phase, coagulation phase, and fibrinolytic phase. So these are the three phases in basic. First, what is vascular phase? So whenever there is tissue injury, the first step occurs is vasoconstriction, constriction of the blood vessel, and that arrests the bleeding. That is the vascular phase. So the vasoconstrictors which are released after tissue injury are serotonin, histamine, prostaglandins. They cause vasoconstriction of the capillaries of the small vessels and that arrest bleeding. So that is the first step of, or it is the first natural step in your body to arrest bleeding. That is vascular. Next is platelet phase. What happens? Circulating blood platelets, they get activated after tissue injury. So whenever there is tissue injury or damage to the vessels, what happens? The endothelial surface get exposed, or there occurs a formation of raw area, or there is damage to the endothelial layer. So whenever there is damage, whenever there is injury, platelet gets activated. They aggregate at the site of injury and they form a plug that is called as platelet plug, and that arrests the bleeding, particularly from small blood vessels and capillaries. So this platelet plug get adhere to the exposed part of the vessel. It adheres to the exposed basement membrane, exposed part of the blood vessel. So whenever there is damage or tissue injury, damage to the blood vessel, damage to the capillaries, that means there is damage to the endothelial layer. There occurs a formation of raw area. Platelet get activated. They aggregate and they form a platelet plug, which adhere to the exposed part and arrest the bleeding. That is the platelet phase. Vascular phase, vasoconstriction. Second phase, formation of platelet plug. And now third phase, coagulation, that is formation of blood clot. The third is coagulation phase, that means formation of blood clot, how a clot is formed. So generation of thrombin and fibrin to form a clot. So it involves number of clotting factors. You already studied in second year the various clotting factors. So there are 1 to 13 clotting factors. These clotting factors get activated via two steps: extrinsic pathway, intrinsic pathway, and then common pathway. So it involves three separate pathways: intrinsic, extrinsic, and then common pathway. And the final product is formation of a blood clot. Final product is formation of a blood clot, and that arrests your bleeding. So that is the coagulation phase. These are the various clotting factors 1 to 13. Factor 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. These are the 13 factors. Factor 1 is fibrinogen, factor 2 is prothrombin, factor 3 is tissue factor or tissue thromboplastin, factor 4 is calcium, factor 5 is labile factor, factor 6 is not there, factor 7 is there, after 5 direct 7, which is a pro-converting or serum prothrombin conversion accelerator. Then factor 8 is anti-hemophilic factor, factor 9 is plasma thromboplastin component, 10 is called start form factor, 11 is plasma thromboplastin antecedent, 12 is measurement factor, and 13 is fibrous factor. So these are the 30 clotting factors in our body. So this is the pathway, coagulation pathway, intrinsic pathway, extrinsic pathway, and then common pathway, and the final product is formation of a clot. So intrinsic, extrinsic, and the common pathway is formation of thrombin from prothrombin. So prothrombin, thrombin. Thrombin causes fibrinogen to fibrin. Fibrin polymer causes formation of clot. And this clot is stabilized by factor 30. This clot is stabilized by factor 30. So final product is the formation of blood clot, which arrests the bleeding. So this is the coagulation phase. So vascular phase, platelet phase, and coagulation phase. These are the three natural mechanisms in your body to arrest bleeding. To arrest bleeding, that is called as hemostasis. Natural hemostasis. And last is fibrinolytic phase. The function of fibrinolytic phase is that the propagation of the clot or formation of excessive clot. Propagation or formation of excessive clot is limited by fibrinolysis. So the body should have balance. Body should have balance formation of clot. So propagation of clot or formation of excess of clot is limited by fibrinolysis. The important fibrinolytic factor is tissue plasminogen activator, which is released from the endothelial cells and which convert plasminogen to plasmin. This plasmin degrades fibrinogen to fibrin and fibrin degradation product, and it prevents excess of clot formation and propagation of clot. So important is tissue plasminogen activator, which cause plasminogen to plasmin, and plasmin is a fibrinolytic agent. So this tissue plasminogen activator is important where it is used in thromboembolic disorders. Drugs which are active at tissue plasminogen activator used in thromboembolic disorders associated with myocardial infarction. So these drugs, tissue plasminogen activator, very important in myocardial infarction. They are effective within 1 to 6 hours of post-infusion, within 6 hours of myocardial infarction. So the main drug which is used as a fibrinolytic drug in myocardial infarction, we already discussed, is streptokinase. The main drug used is streptokinase. And other drugs which are used as a fibrinolytic drugs or thrombolytic drugs. Our main aim in myocardial infarction is thrombolysis, to cause lysis of the blood clot and to open the blood vessel. To cause lysis of blood clot and to open the blood vessel. That is our main aim in myocardial infarction. So the drug used in myocardial infarction is thrombolytic drugs or fibrinolytic drugs. The main drug used is streptokinase. Another drugs are tissue plasminogen activators, which include reticlase, tenecteplase, we already discussed. So these drugs act as a tissue plasminogen activator. They cause formation of plasmin from plasminogen, and plasmin causes degradation of fibrinogen, and it causes lysis of the clot, that is thrombolysis of fibrinolysis. That is thrombolysis of fibrinolysis, and it opens the blood vessel. So these are important where in thromboembolic disorders, particularly myocardial infarction. Now we start discussion on bleeding disorder. So this is the introduction part. You should know first the natural mechanism in your body to arrest bleeding. Now bleeding and clotting disorders. First we discuss about bleeding disorders. So hemostasis depend on vessel wall integrity, means capillary integrity. Adequate number of platelets are necessary to form platelet plug. Proper functioning of platelet is necessary for their activation, for their aggregation, and for their formation of platelet. Then adequate levels of clotting factors are important in body, and proper functioning of fibrinolytic pathways as well. The body's hemostasis depend on these 5 factors. Now vessel wall defect include, that means your capillaries are fragile, your blood vessels are fragile. So these disorders include, everyone know it about vitamin C deficiency, that is scurvy. It's scurvy because of vitamin C deficiency, the capillaries are fragile, there occurs bleeding. So you should know that there is gum bleeding in vitamin C deficiency. So why this gum bleeding occurs? This is because of fragility of the capillaries, which is necessary for vessel wall integrity. So vitamin C is necessary for vessel wall integrity. If there is deficiency of the vitamin C, that means capillaries become fragile and that results in bleeding. There is some bacterial viral infections also called damage to the vessels or fragile capillaries and results in bleeding, that is formation of petechies like in dengue fever or any other viral infections. The purpura, petechi, these are nothing but it is because of the defect in muscular integrity that results in bleeding. So these are the vessel wall defects. The most common is vitamin C deficiency, that is scurvy. Now platelet disorders. Bleeding disorders mainly include platelet disorder. So platelet disorder include either decreased number of platelet. Decreased number of platelet is called thrombocytopenia, means low platelet count. And thrombocytopathy means it is the impaired functioning of platelet. Platelet number is adequate. Platelet count is adequate, but platelets are not functionally effective. There is some genetic problem, there is some enzyme defect, whatever. Platelets are not functionally effective. They are not able to do their function properly. That is called thrombocytopathy. So decreased count is thrombocytopenia, and impaired functioning is called thrombocytopathy. So before that, you should know about somewhat about platelets. As we study about RBC, just like that, we should know about the platelet. So they are formed in bone marrow. The progenitor cell of platelet is megakaryocyte. Normal platelet lifespan is 10 days, 4 to 10 days. Every 10 days, platelet pool is replenished. Normal platelet count is 1,50,000 to 4,50,000. Platelet count. Thrombocytopenia is usually called when platelet count falls below 1 lakh. Usually called when platelet count falls below 1 lakh. The normal range is 1 lakh 50 to 4 lakh 50. So thrombocytopenia means inadequate number or decreased count. Thrombocytopathy means functioning is impaired. Number is adequate. So thrombocytopathy include impaired functioning include drug induced. The most common example for this thrombocytopathy is aspirin, the drug which is used as an antiplatelet drug. It affects the functioning of platelet. It is used to prevent formation of blood clot. So it is used to prevent formation of blood clot. It is used mainly as an antiplatelet drug. It prevents platelet plug formation. So it is important in myocardial infarction or any other thromboembolic disorder. It has been used like in stroke, myocardial infarction, pulmonary embolism. So the role of aspirin is mainly antiplatelet drug. It irreversibly binds to the platelet for its entire lifespan, that is 14 days. It prevents formation of platelet clot. So it affect the functioning of the platelet. It will not decrease platelet count. Aspirin will not cause decreased platelet count, but it affects the functioning of it. It prevents aggregation of platelet. That is the example for thrombocytopathy. Another drug which causes thrombocytopathy is NSAIDs. Diclofenac, ibuprofen. NSAIDs also affect platelet functioning. So in bleeding and clotting disorder, these two drugs are contraindicated. In patient with known bleeding clotting disorder, aspirin, NSAIDs are contraindicated because they affect platelet functioning. Already platelet count is low, and they also affect the platelet functioning. So these two drugs are contraindicated. Now causes of thrombocytopenia. So decreased platelet count below 1 lakh, that is thrombocytopenia. What are the causes of thrombocytopenia? To decrease the count of platelet, either two mechanisms. Either there is decreased production or there is increased destruction. Only there are two ways. Either there is decreased production or there is increased destruction. So the causes for decreased production. So production occur in bone marrow. Production occur in bone marrow. So causes for decreased production include bone marrow diseases like aplastic anemia, megaloblastic anemia. We already discussed in here. Then drug-induced marrow suppression, chemotherapy, radiotherapy in cancer patients which cause bone marrow suppression, viral infections. Any viral infection, many drugs, chemotherapy, radiotherapy, they cause bone marrow suppression. Bone marrow suppression. So that is the cause for decreased production by bone marrow. Aplastic anemia, megaloblastic anemia, drug-induced viral infections, chemotherapy, radiotherapy. or infiltration of marrow, means metastasis in the marrow, infiltration in the marrow, like blood cancer, like leukemia, lymphoma, means there occurs there occurs accumulation of malignant cells in the marrow. So, if there occur accumulation of malignant cells in the marrow, it will affect the functioning of normal cells. It will affect the functioning of normal marrow. So, infiltration of marrow in leukemia, lymphoma, fibrosis, metastatic cancer also affect the functioning of marrow, and that also result in decreased production. So, decreased production occurs with diseases of bone marrow, like aplastic anemia, neoplastic anemia, drug-induced viral infections, chemotherapy, radiotherapy, or infiltration in cases of leukemia, lymphoma, and metastatic cancers. Now, increased destruction. This is causes for decreased production. Now, increased destruction. So, increased destruction, non-immune mechanism, immune mechanism. Immune mechanism means antibody-induced destruction. Non-immune means not antibody induced. So non-immune destruction occurs in DIC. DIC is nothing but disseminated intramuscular coagulation, in vasculitis, in sepsis, in prosthetic cardiac walls. So these are the causes for non-immune destruction. Non-immune destruction of peptide occurs where vasculitis. This vasculitis can occur in autoimmune diseases or in viral infections. Vasculitis means inflammation of the capillaries and small blood vessels. So this can occur in many viral infections and in autoimmune disease. So DIC, disseminated intravascular coagulation, vasculitis, sepsis. In sepsis, there is thrombocytopenia because of non-immune destruction. Then prosthetic cardiac valves means in mitral stenosis, aortic stenosis, when you replace the cardiac valve. The definitive treatment for mitosplenectomy stenosis is to replace the damaged valve. So when we replace the damaged valve, that is called as prosthetic cardiac valve. So in prosthetic patient with prosthetic cardiac valve, there can occur non-immune destruction of platelet and that results in thrombocytopenia. That results in thrombocytopenia. So these are the causes for non-immune destruction. Immune destruction, most common cause is ITP, that is immune thrombocytopenic purpura. Very common disorder in our India. Immune thrombocytopenic purpura, very common disorder or very common cause of pneumonia, particularly in children. So immune destruction means antibody mediated destruction that occurs in SLE and ITP. SLE is autoimmune disease, systemic lupus erythematosus, and this is immune thrombocytopenia. Another cause for thrombocytopenia is increased sequestration by enlarged spleen. Whenever there is splenomegaly, we discuss in liver cirrhosis that whenever spleen is enlarged, there is splenomegaly. It causes increased sequestration of all cells. In body, whenever spleen enlarges, there is splenomegaly. It may cause, particularly in passive splenomegaly, it may cause increased sequestration of the cell or excessive sequestration of cells by the enlarged spleen because it is a function of spleen. So there occurs pancytopenia in splenomegaly. Pancytopenia means decreased RBC, decreased WBC, and decreased platelet. So increased sequestration by enlarged spleen. The drug induced, particularly alcohol and steroids. These are the two drugs which can cause alcohol and steroids. So these are the causes for thrombocytopenia. Either decreased production or increased destruction. Increased destruction, non-immune, immune, increased sequestration, and drug. The most common disorder or the most common cause of thrombocytopenia is ITP, that is autoimmune thrombocytopenic purpura, or it is immune thrombocytopenic purpura. It is the most common cause of acute onset of thrombocytopenia, particularly in children, in a way the otherwise well child, estimated about 1 in 20,000 children. A recent history of viral illness sometimes present in 50 to 60% of cases of childhood ITP. 1 to 4 weeks after exposure. 1 to 4 weeks. 1 to 4 weeks after exposure to a common viral infection, there can occur ITP. The age group most common is 1 to 4 years. ITP seem to occur more often in the late winter and spring after peak season of viral respiratory illness. So late winter and early spring. This is the season for viral infection. So 1 to 4 weeks after viral infection, there can occur or patient presented with thrombocytopenia, that is immune thrombocytopenia purpura, common in children. The age group is 1 to 4 years. An antibody directed against the platelet surface developed with resultant sudden onset of thrombocytopenia. So it is antibody mediated destruction of platelet. After binding of the antibody to the platelet surface, circulating antibody-coated platelets which are recognized by the FC receptor on the splenic macrophages and spleen remove that. The function of spleen is to remove the foreign particle. That is the function of spleen. So antibody-coated platelets are removed by the spleen, and that results in thrombocytopenia. Most common viruses have been described in association with ITP include Epstein-Barr virus. In some patients, ITP appears to arise in children infected with Helicobacter pylori, rarely after measles, mumps, rubella, all these are the viruses. So, after a history of viral illness, there can occur ITP. This is the new classification of ITP. Newly diagnosed case, if the duration is less than 3 months, history less than 3 months. If thrombocytopenia persists for 3 to 12 months, then it is called persistent ITP. If more than 12 months have passed, patient with persistent thrombocytopenia, then it is called chronic ITP. So less than 3 months it is acute or newly diagnosed ITP. Up to 12 months it is persistent ITP. After 12 months it is chronic ITP. So acute, chronic and persistent. Now the clinical manifestation, the classic presentation of ITP in a previously healthy child, 1 to 4 year old child who has sudden onset of generalized petechiae and purpura. Sudden onset of generalized petechiae and purpura, bleeding spots all over the body. Often there is bleeding from gums and mucous membrane, particularly with profound thrombocytopenia. So, in bleeding disorders, particularly in thrombocytopenia, bleeding is rarely massive. Bleeding is rarely massive. Bleeding can occur, but it is rarely massive or it is rarely life-threatening. Life-threatening occurs when platelet count fall below 10,000. Life-threatening bleeding occurs when platelet count fall below 10,000. So there is bleeding from gums, from mucous membranes of gastrointestinal tract, genitourinary tract, anything, particularly profound hypertension. So it becomes life-threatening when platelet count fall below 10,000. See, this is the patient's presentation with bleeding disorders. So this is petechiae, mucous bleeding. This is called purpura. This is called purpura. This is petechiae. Formation of small bleedings. Petechiae is 1 to 2 mm. Petechiae is 1 to 2 mm. Purpura is larger than petechiae. And ecchymoses are larger than purpura. So up to 1 to 5. So this is 1 mm petechiae, 1 to 2 mm, and ecchymoses are larger than purpura. So small bleeding spots called petechiae, larger than this called purpura, and ecchymoses larger than this. This is mucous bleeding. So this is the patient presentation with ITP or any platelet disorder or patient with bleeding disorder. So petechiae, purpura, ecchymosis, this is the patient's presentation in any bleeding and clotting disorder. So it is the classification mild, moderate, severe. Mild, moderate and severe depending on the basis of symptoms, signs and platelet count. ITP is classified. Class 1 no symptoms, class 2 mild symptoms, just like bruising, petechiae, occasional, epistaxis, organ bleeding, and very little interference with daily living. So it is mild, class 1, class 2. Class 3 is moderate, more severe skin and mucosal lesions. More troublesome epistaxis and menorrhagia. So here bleeding is mild, not interfering with daily giving. Minor bleeding from nose, minor bleeding from gums. So bleeding is minor, not interfering with giving. Here bleeding is more severe. There can occur troublesome epistaxis, means bleeding from the nose, menorrhagia, excessive bleeding during menses, particularly in females. Severe, there is severe menorrhagia, severe epistaxis, melena, means bleeding in blood in stool that require patient may land in shock or patient require hospitalization and blood transfusion. So symptoms are severe, serious and interfering with the quality of life. It is severe. So mild, moderate and severe depending on the bleeding and platelet count. The patient usually presented with petechiae, purpura, bleeding from mucosal surfaces, bleeding from gums, then bleeding from gastrointestinal tract in the form of melena, then bleeding from genitourinary system in the form of menorrhagia, in the form of hematuria. Hematuria means blood in urine. Menorrhagia means excess of bleeding during menses. Then melena means blood in the stool. So like that. That is the patient presentation. Now the investigation in a patient with bleeding disorders. So whenever patient come to you with no case of bleeding disorder or with low platelet count or with bleeding over the body means petechiae, purpura, gum bleeding, mucosal, etc. In any form, whenever patient comes, if you are suspecting that patient is suffering from some bleeding disorder or maybe patient having low platelet count, if you are suspecting, your basic investigation include first to see the platelet count. And to see the platelet count, the investigation required is complete blood count. The first investigation is complete blood count to see platelet count along with peripheral smear examination. In peripheral smear, you can see some abnormal cells, or you can again count the platelets. So CBC with peripheral smear examination. Then your next investigation should be clotting time, bleeding time, CTBT. So first CBC, then CTBT. CTBT means clotting time and bleeding time. The clotting time normal is 4 to 6 minutes. Bleeding time normal is 1 to 3 minutes. So clotting time, bleeding time. So in platelet disorders or in bleeding disorders, bleeding time is not prolonged. Clotting time can be normal, but bleeding time is prolonged. So most common investigations CBC, CTBT, and then bone marrow examination to rule out bone marrow disorders. These are the basic investigations: CBC, CTBT, and bone marrow, and peripheral smear examination. So thrombocytopenia, when the count is 50 to or above 50, usually patient having no bleeding symptoms or signs when count is above 50. When count fall below 50 or 20 to 50, then symptoms can occur. When count is between 10 to 20, it can be life-threatening, patient require hospitalization. And when count is less than 10,000, there can occur spontaneous intracranial hemorrhage and death can occur. His platelet count below 10,000 is very, very risky. Death can occur because of intracerebral or intracranial bleeding. So whenever there is platelet count above 50, there is no risk or it is not life-threatening. And usually no manifestations occur. Below 50, manifestations can occur. Below 20, it can be life-threatening or patient require hospitalization, but below 10 is always life-threatening. Treatment. So treatment will not usually require until the count falls below 30 or until bleeding manifestations present. Any patient with bleeding disorder (ITP), treatment usually not required until count falls below 30 or bleeding manifestations. So, what are the options? As it is a autoimmune disease, there is antibody-mediated destruction of platelet. It is autoimmune disease. ITP is a autoimmune disease, formation of antibodies against platelet, which cause destruction of platelet. So, our aim in treatment is, as it is autoimmune disease, so every autoimmune disease, the treatment plan is always to do immunosuppression. The treatment plan is immunosuppression. You have to suppress your immunity. And the options for immunosuppressions, no doubt, corticosteroid. It is the most common drug used as an immunosuppressant. corticosteroids used in any autoimmune disorder. In any autoimmune disorders. So our aim in any autoimmune disorder is to decrease your immunity to do immunosuppression. The most common drug is steroids. So the treatment in ITP is steroid to do immunosuppression. So that will decrease the antibody level in your body and decrease platelet destruction. Other drugs which are used as an immunosuppressant, these are cyclophosphamide, azathioprine, and rituximab, and intravenous immunotherapy.